Okay, so we started talking about anatomy. We talked about the steps in respiration. We talked about all the way down to, I think, the alveoli, right? I told you about the way the bends are, the reason that you don't have noses where your nipples are, or because you have to have those bends. You have to be able to get the air down, but you have to process the air at the same time. You have to warm it. You have to make sure it's moistened. You have to make sure you clean it as much of the dirt and bacteria out of it. And so you have this long bending pathway getting down to the alveoli. Okay. When we get down into the alveoli, and I'm going to say this because the book a lot of times refers to the lungs, the lung, but the lung is made up of a lot of things. In the back of your mind, you have to keep thinking, when you see the lung and they use the word the lung, a lot of times what they're actually talking about is the entire bundle of alveoli. So they use the word alveoli, plural alveoli, and the word lung synonymously, as if they're the same thing. So when they talk about air getting into the lung, what are they actually telling you air is getting into? The alveoli. Because just like the blood, you get no exchange of oxygen at the arterioles, no exchange of oxygen in the nose, no exchange of oxygen at the level of the trachea or the larynx. None of those structures will exchange oxygen with your blood. None of them. The only structure you can exchange are the small, single-cell thick structures, which are called the alveoli. It's just like exchange of blood. You don't get exchange at the arteries, the arterioles. You don't get exchange at the venules or the veins. The only place you get exchange is at the capillaries. One single cell thick with easy diffusion back and forth. So when you see the word lung, you want to think of this as the bundle of alveoli they're talking about. Does that make sense? So just, you have to plan it in your mind, because every time I read a book, I hate it when they do that. They don't make it clear that when they switch back and forth between the word alveoli and lung in general, that they're actually the same thing in reality. Okay, so we've got these bronchioles, which are similar to what in the bloodstream? The arterioles, right? And what makes them similar is that these are going to be the major what vessels? Resistance vessels. They have a lot of smooth muscle around them so they can adjust their size to control how much what. If they're changing the size, that's the radius, what are they changing directly? The resistance. And what are they indirectly changing because they change the resistance? The flow. So it's the same concept we saw before. You can change the resistance, or the size, changing the resistance, which changes the flow. And what disease do you think we're going to talk about that talks about people not being able to get the airflow in because these muscles squeeze down really tight? Asthma. So what happens is they squeeze, in asthma, you squeeze these smooth muscles, and what's to do the radius of the bronchioles? It squeezes them down, right? It constricts them. What's it doing to the resistance? It increases the resistance in the airway, so what's going to do to their flow? Decreases their flow. It's the same concept you learned back in cardiovascular. You're just going to go over it again, thinking about air instead of blood. Okay, so when we get down to these alveoli, you can see these bundles of alveoli, they're all connected to each other. You have a pathway that goes from the bronchioles directly into the alveoli, but you also have passageways in between alveoli, and they're called the pores of cone. So the air can go from this alveoli to the next one, and from this one to that next one, and that one to the next one. So that it's not just filling one alveoli up at a time, it's filling the entire bundle up at one time. You bring air in, and it exchanges all through those alveoli. Yep, they're passageways from one to the next alveoli. So if I could see right between this wall, there would be one here connecting over to the other one. There would be this one connecting to the one behind it, this one connecting to the one behind that. It's kind of like a lateral circulation. Instead of going one path, the bronchiole into the alveoli, it can actually go alveoli to alveoli all the way along. So they all expand as one bundle. And this got kind of blurry, yeah? It would be kind of similar to the idea of a gap junction where one will allow air going to the next one, to the next one, to the next one. And then this got a little bit blurry, but hopefully you can see up there. Here you can see the inside of the alveoli. Here you can see the blood vessels. What kind of blood vessel is this getting exchanged? The capillary. So you see the red blood cells, and you can see the exchange of the oxygen and the CO2 going back and forth really quick. When you look at the alveolar wall, there's only one cell here in this alveolar wall. There's only one cell in the outside of this capillary wall too. So if there's only one thin flat cell here and one thin flat cell here, what's that do to the rate of diffusion? It increases the rate. It makes it a lot faster. If you put layers, like if I put a bunch of mucus inside of here, I thicken that wall. What's it do to the rate of diffusion? It decreases it. So if you have a lot of mucus on the inside, let's say you have bronchitis and you have lots of mucus built up in there, what's it doing to your rate of diffusion across that alveolar wall? It's slowing it down, right? And that's why they feel like they have to breathe heavier, because they're trying to get better diffusion in there. Right, so the types of cells you have to know in the alveoli, the first one's the type 1, and it actually makes the wall. It makes the alveolar wall. It's that single cell that makes the wall of the alveoli. Type 2 cells make something called surfactant, S-U-R-F-A-C-T-A-N-T, surfactant. And we're going to talk about surfactant in just a little bit. What surfactant, its primary job is to make it easier to expand that alveoli.
That's the fluid.
It's the fluid that's on the wall of the alveoli, right? The technical term is it reduces surface tension. So it makes it easier for you to expand the alveoli. The word we used with the blood vessels was made more stretchable, which was compliant. It makes it more compliant. The more this surfactant stuff you have, the more compliant that alveoli becomes. So it can become bigger. What would be the benefit of becoming bigger? It will allow more air to come in, right? And then the last one, the macrophage, they call them an alveolar macrophage because they're specific to this tissue. They were a monocyte. When they get over into the lungs, they turn into this alveolar macrophage. What do you think they're there for? To eat dust and bacteria that gets in. What's really interesting, if you ever get a chance to Google it, I should probably Google it sometime and borrow the picture, but if you look at asbestos, asbestos can't be digested. When it gets in your lungs, these macrophages try and eat it, and it's like a spear going right through the macrophage, and it kills the macrophage. It's crazy watching it. When you look at the walls again, what's the wall made out of? What type of cell? It's the type 1. When you look at this structure up here, this is making what? This surfactant, which is that liquidy goo that's covering the entire surface area. It's like a real thin mucousy layer. And then this last one, alveolar macrophage, what's it for? Eating bacteria and dust. And then you can see how thin the alveolar wall is. You can see how thin the endothelial wall is so that you get easy diffusion back and forth.
So this is in every single alveoli?
This is every alveoli, yeah.
And how many alveoli did you say?
Lots of them.
Huh?
Lots of them.
So the macrophages are in the lung itself and not in
The macrophage are in the
lungs, in the alveoli themselves, not the...
You're right. The alveolar macrophages hang out inside the alveoli, waiting for bacteria to get in. It was in the blood originally, and it moved out of the blood. It was a monocyte when it was in the blood, and then when it moved out of the blood and stayed in the lungs, it became an alveolar macrophage. There wouldn't be any reason for it to go back in. All right. So surfactant is made in which of the cell populations? It's type 2. What's its function? Yep. Decrease the surface tension so the alveoli can do what? Expand better. And just to give you an idea why this is important is that you don't make surfactant until about 2 weeks before you're born. So babies are born way prematurely. What do you know about their lungs? They can't open them completely, right? Because they don't have the surfactant, so they can't open the lungs up and get enough air in when they're born too prematurely. Okay, so lungs occupy most of the thoracic cavity. What's the other major organ in the thoracic cavity? The heart. When you look at the lungs, you have 2 of them, and they're primarily going to be all these alveoli, but you also have branching airways. So you have the trachea that's coming down, it's that series of C rings that go all the way down, and then it branches into 2 major pathways. What were they? The bronchi, right? So the bronchi go back and forth. You have a left one and a right one. And then they spread into what's? Bronchioles, and the bronchioles end up in these little groups of what? Alveoli. So lots of branching pathways. You have the big lumps of alveoli, and the alveoli is the bulk of the lung. And then you have pulmonary vasculature. This is talking about the blood vessels going through the lungs. So that's carrying blood up through the lungs, ideally doing what? Picking up oxygen and dropping off CO2. What was the name of that blood flow going through the lungs? Perfusion. Yep. So perfusion. And then lots and lots and lots and lots and lots and lots of elastic tissue. What does elastic let you do? So compliance is the stretchability. What's the elastic? The snap back, right? When you lose the elasticity of your waistband, you can still stretch it out, right? But what's it not do anymore? It doesn't snap back. Yeah, so when you stretch it out and it gets that crackly sound, you know it's time to get some new ones, right? Yeah, this guy thing, right? Anyway, so lots and lots of elastic tissue, so it snaps back. That way when I'm breathing, I take a deep breath. As soon as I let go of that breath, what do my lungs do? They snap back to the original size. As we age, do they snap back as well? Nope, which means do we hold more oxygen in our lungs when we're older? We actually do. We can't get it out as well when we're older, right? And we'll talk about that later too. Right, and the only muscle within the lungs is a smooth muscle. There's no skeletal, there's no cardiac in the lungs themselves. It's smooth muscles. You're going to find that we'll talk about skeletal muscle later and how it controls breathing, but skeletal muscle is not in the lungs. It's actually in what structures around the lungs? The ribs. It controls the size of the ribs, which are going to control the size of the lung. Right, so in the lung, it's smooth muscle. Between the ribs, it's skeletal.
So what did you say perfusion is again? The blood?
Perfusion is the blood that's going through into the lungs. So when you're carrying blood into the lungs, it's called perfusion. When you're carrying the oxygen or air into the lungs, it's called respiration. Or technically ventilation, which is part of respiration. Okay, and then the pleural sac is just like when we have the pericardial sac. The pleural sac is that water balloony structure that wraps around the lungs. So if I look at it, remember the layers of the pericardial sac? What was the one that actually touched the heart? It was called the what layer? The visceral layer. What do you call the one that doesn't actually touch the organ? The parietal. So you have the same two layers. They wrap around. You have the parietal, which is on the outside part that doesn't touch the lung, and then you have the visceral layer that actually touches the lung. So if you look really close, I don't know if there's a picture on the next page or not. Yeah, there we go. So here you have a lollipop, or I gave you the example of a fist later, or before. You push it down into the water balloon, it just wraps the water balloon around it. If this were the lung, what's the layer that's actually making contact called? The visceral. And then where it separates and comes out here, it's the parietal. So what do you think you call the space in between? In the pleural cavity. What do you think you call that water inside? Pleural fluid. Yep. So not tricky. What benefit did the fluid have for the heart? Reduce friction. Same idea here. This also is interesting because in the lung, it creates this hydrostatic pressure, or actually like a hydraulic pressure. So if I pull, and I'll go into this in better detail, but if I pull on this side of that water balloon, water doesn't stretch. It hates being stretched. So if I pull on this side, all these water molecules holding hands are going to do what to this side? Pull it with. As I pull on this side, the other side just follows it right out. So as I pull on this side of the water balloon, what's it do to the size of the lung? It increases the size of the lung. Keep that in mind. We'll keep talking about that over and over again. So think about it. When I pull on this side, all that water holds hands. What would happen if I punctured this? What would the water want to do? It would leak out, yeah. And if I start pulling on this wall, if I have a hole here, what's going to go in? Air. It's going to totally screw up what's going on with the lungs. It's going to make a huge mess. Anybody know what that's called when I puncture this wall? Something thorax. Pneumothorax. Yeah. So pneumothorax. Punctured lung. Did we cover all the words here? So pleural cavity, intrapleural fluid, and then pleurisy is inflammation. Yep, inflammation of that sac. And just like the heart, if that sac becomes inflamed, you hear this like leather rubbing sound. So that's kind of interesting. The heart and the lungs are right next to each other. If you're listening and you heard that leathery sound, which one is it? Is it the heart or the lungs that have an inflamed sac around them? Who knows? What could you do to distinguish between the two? Tell them stop breathing. If you still hear that sound, what is it? It's the heart, right? So it's hard to tell them stop beating your heart so I can identify the lungs. But yeah, they have the same sound. They're very similar structures. If you know if you tell them stop breathing, you know exactly what the problem is. If that sound stops, it was the lungs. If the sound doesn't stop, it's still the heart. Okay, respiratory mechanics. So you have to pay attention to this, and this is kind of a deep concept, but when you look at how air moves, you're not forcefully pushing air up into your nose and down into your lungs. You're actually manipulating your rib cage, that pleural sac, to manipulate the size of the lung. So it's kind of an interesting process that we've developed here. You have to look at three pressures, and the first one is the atmospheric pressure, and that's all of the air around you on the outside. So if we're talking about atmospheric pressure, it's the air all through this room. If we walk outside, it's the air all over the outside environment. That's the atmospheric pressure. That's everything outside your body. And at sea level, we're at about 760 millimeters of mercury is our air pressure. So it's 760 and then mm, capital H, little g. 760. Sometimes you hear it referred to as atmospheres or ATM. It would be 1 atmosphere exactly. You have 1 atmosphere pushing on you, 1 atmosphere of all the air molecules above you pushing down on you. To give you something in perspective, if anybody here gone swimming and you swim really deep, how does it feel? It feels like it's squeezing harder and harder. It's because all of that water above you is pushing down on you. All of its weight's pushing down on you. If you're standing out here in the environment, all of the air molecules going from here all the way up to basically our entire atmosphere are pushing down on you. You feel weight. That's atmospheric pressure that's pushing down. If you go up into Colorado, what happens to that atmospheric pressure? If you go way up in the Rocky Mountains, it gets lighter. So that pressure pushing air down into your lungs is doing what? Getting harder or less? It's becoming less. It's not pushing into your lungs as forcefully as you get down here in this beautiful, wonderful corn-fed state. Okay. Colorado sucks, right? Anyway, number 2, intraalveolar pressure. This is where you're going to predict this is at. Intraalveolar is in the alveoli. It's the air pressure that's inside the lung space, right? Inside the alveolar space. This is inside your body, the pressure in there. This is the one we're really trying to manipulate. We want to manipulate this so we can move air back and forth. And the third one's the intrapleural pressure. Where's that? In that watery cavity space. This one doesn't change very much at all. This one's pretty fixed because those water molecules, they don't like to bend, they don't like to be squeezed, they like to stay very consistent. The important thing about this space is that it helps hold your lung to the rib cage. If you expand your rib cage, what's this sac going to make your lung do? Expand with it. It pulls on it. It's like I said, pulling on one side of a water balloon, the other side has to follow with it. The only time that this changes a lot is if you have a puncture to that sac, and we'll talk about that too. So these are 3 pressures you want to pay attention to. You know the rule of pressure. How does pressure move? Always from high to low, naturally, right? That's the way everything in the universe wants to go. From where it's really crowded to where it's less crowded, where it's high concentration to low concentration, pressure is exactly the same. So just thinking about that, if I tell you the atmospheric pressure is really, really high, 760 millimeters of mercury, and I tell you the intraalveolar pressure, the air pressure in your lung, is at 700, where's the air want to move? It wants to go from atmospheric into the lungs because it goes from high to low. What if I squeeze on my lungs and I raise that pressure? I make it up to 800 inside my intraalveolar. Where's it want to go? Outside to the 760 where it's lower. Are you going to be able to manipulate your atmospheric pressure very fast? It doesn't change very quickly at all. It's pretty consistent. You know, we get a big storm and it changes a little bit, but not that dramatically. This is the pressure that changes the most to manipulate breathing. All right, so you have to remember these spaces. What do I call all of this outside my body? Atmospheric. What do I call all of this inside the lung? Intraalveolar. What do I call this in the watery sac? Intrapleural, right. When you see this mmHg, millimeters of mercury, just so you understand what it is, scientists decided we've got to figure out this measurement for pressure. So they took a little jar of mercury. Mercury at room temperature is liquid. It's the stuff that if you break a thermostat or a thermometer open and you play with it, it'll kill you kind of stuff. But it's liquid at room temperature. When I was a kid, I remember how fun it was to play with, and now I'm thinking, damn. When I look back at my childhood, I think, okay, I've got like 15, 16 more days to live. But it's liquid at room temperature. What they do is they put it in this vacuum tube. There's no air pressure in this tube. And then they take a device and they flip over a test tube into that mercury so that it's dipping down into the mercury. Then suddenly they open the vacuum and they let all the air pressure come rushing in. It rushes in and it pushes down on that liquid and it starts pushing it up the tube. Guess what? At sea level, how far up the tube it goes? 760 millimeters up the tube. That's how they measure that. So if we took the same test tube up to Colorado, it'll drop down lower down the tube. And I don't know what the pressure in the Rocky Mountains is, but it's a lot lower. Okay. So we're going to start manipulating these pressures and squeezing things around the lungs to do what to the air pressure in the lungs. If I squeeze the structures around, it's going to do what to the pressure? Increase it. Where's the air going to want to move if I increase the intraalveolar pressure? It wants to go out. What if I pull out on these alveoli and I drop the pressure? Where's the air want to go? In towards lower pressure. So this picture we're going to come back to in just a little bit. All right, so the lungs follow the chest movement for two reasons. And the first one is because of the intrapleural fluid surface tension. This is a fancy way of saying the water's holding hands, right? So all the water in that water balloon, they're all holding hands. Cohesiveness. It's molecules, the same molecules holding hands, or cohesion. They don't want to move. They will hold hands, but they don't want to stretch. They don't want to compress. Does that make it more clear? They don't want to separate. There's another way to look at it. It's like me having this whole front row hold hands, and they're all holding like this, right? But they don't like each other very much, right? So do they want to snuggle up? Hell no. They want to keep their distance. If I pull on the hands all the way at this end, what happens to the whole chain? They all move equally across, right? If I start pushing on them at this end, what do they all want to do because they don't like each other? They all move equally away, right? So they all move in the opposite direction. That's what those little water molecules are doing. So this intrapleural fluid surface tension is them holding hands but keeping their even distance apart. They don't like to be compressed. They don't like to be pulled apart. It's called cohesion, water molecules holding hands with each other. Number 2, transmural pressure gradient. And this is talking about across that water balloon wall. How many water balloon walls do you have? 2. You have the visceral wall and you have the parietal. Remember, there's no breaks, but you have the side that's touching the organ, you have the side that's touching the outside other organs. Right? So the first one's across the wall of the lung. This is the one that's touching what structures when we say the lung? These are the ones touching the alveoli, right? So this is the visceral wall. When we talk about across the thoracic wall, what would that be? It's touching the thoracic wall out here, the ribs, that would be the parietal layer. So we have this pressure gradient that's across the alveolar or the visceral wall, and we have one that's across with the rib cage, which is the parietal wall. So here's a picture of them. Here you have this wall along here. What would that be? That's the visceral wall, right? That's the wall attaching to the lung. Then you have the wall out here, which is touching the rib cage, which is the what wall? The parietal wall. So these are 2 transmural pressure gradients, one here across the visceral and one here across the parietal wall. So if I start pulling on this wall, what's that wall want to do with it? Opposite direction, stay put, or move with it? Moves with it. Yeah, so it moves with it. If I start compressing this wall, what's this wall want to do? It wants to compress too.
Where it says thoracic, and then it points to that. I thought that was the parietal.
It is. It's the same thing.
Oh.
Yep, the thoracic wall is touching the rib cage. It's saying the thoracic cavity wall. Yep. Okay, so here's a concept to remember. Neither the lungs or the thoracic wall are actually in their natural position. What's interesting is that your muscles, do they have elastic properties? Yes, they do. Remember, you contract a muscle and its elastic property brings it back to its natural position. So all the skeletal muscle in your rib cage, they have an elastic property that wants them to pop out. They want to go and pop outwards. These muscles are always trying to expand your lungs. But the alveolar wall, the alveoli themselves, they have their elastic properties that are trying to squeeze them back into their snap back, smash little position. So what are they trying to do to your lungs all the time? They're trying to collapse them, right? They're trying to pull the lung in, where the muscle out in the rib cage is trying to pull the lung out. So it's like both of them are doing what? They're pulling in opposite directions. They're fighting against each other. So neither of them are natural. What would happen if I broke that wall that's holding them together? What would the lungs do? They collapse. They shrink in. What would the rib cage do? Expand out. So when somebody has a collapsed lung, how do the ribs look? Look expanded. It looks like they're getting a full lung full of air, right? But are they? No, because if you snap an x-ray, what's going on with their lung? It's snapped down. Those 2 walls are always pulling against each other. They're always pulling in opposition. Always. If you break the walls, then they snap into their natural positions.
So the muscle inside tries to push what out?
The skeletal muscle is trying to pull the wall out, pull the rib cage out.
Oh.
Yep. The alveolar wall is trying to do what with the lung? Collapse it in, pull it in. So when we talk about those transmural gradients, we're talking about the thoracic wall or the parietal wall that's trying to pull outwards, and we're talking about the visceral wall that's trying to pull inwards or collapse the lung. So if I ask a question like this is exactly like test questions in the past. Why do the lungs follow the chest wall? How about number 3? The air in the pleural cavity acts as a suction to hold the parietal and visceral pleural together. What's wrong with that? The very first word. What made this wrong? It's fluid, right? It's not air. You shouldn't have air in that wall, so you can get rid of that right away. How about a decrease in surface tension between the parietal and visceral pleura and transmural gradients? Look in your notes. Look back in your notes. Look at the heading that says the lungs follow the chest wall for 2 reasons. See that? It's exactly like the notes. Not trying to trick you. I'm just making sure you get the points. So the lungs follow the movement for 2 reasons. Because the intrapleural fluid tension, the transmural gradients. Okay. So the transmural gradient can be across the wall of the lung and across the thoracic wall. And there they are. Number 1's the right answer. Okay, that pneumothorax. I already told you, I gave you a heads up. What is a pneumothorax?
Collapsed lung.
A collapsed lung. Yep, it's a fancy way of saying a collapsed lung. You broke that sac. Something broke the sac. Maybe it was a nail gun accidentally shooting into their chest wall and it popped the sac. Maybe it was a bacteria that destroyed from the inside and ate through the alveolar wall, popped the sac. Maybe it was a stab wound. Maybe it was a gunshot. It could have been a lot of different things. There's spontaneous pneumothorax too. People that just have a genetic predisposition to have weak walls there. You know, too much stress or pressure could pop that wall. So pneumothorax is popping that wall. So if you puncture the wall, the atmospheric pressure actually equilibrates with the intrapleural pressure. If you look before, the intrapleural pressure was just a little bit lower. See? Outside 760, this always stays slightly below atmospheric. It always wants to stay a little bit below. If I pop this wall, what happens here? The pressure pushes in until it hits what? Equilibrium on both sides. If you hit equilibrium, your lungs can't expand. You always have this little bit of tension in the water here, creating that pull. Okay, so here's an example. If we puncture from the outside, boonk. Remember, this is about 756 in here. What's going to happen? It equilibrates with the outside pressure. What if I puncture it from the inside, like this? It'll do the same thing. It'll equilibrate with the inner pressure, which is also equilibrated with the outside pressure. So either way, boonk, you have the same pressure across here. It doesn't matter how hard you pull the lungs, because people with the collapsed lungs, you watch them, they're going, and they're like struggling for air, right? You can watch their rib cage expand, but what are you not hearing? You're not hearing the air go down in it because they're not expanding the lung itself. So they can raise the chest, you can contract those muscles, but no air is coming down because they have a puncture here.
They can't just bring that on the other side.
No, they'll get some air over here, but they're not going to get even amount of air because every time they pull on the chest, only this side's getting some expansion, but this side's getting nothing at all.
Can a person still survive flying on lung?
Yeah, you could actually survive on lung, but man, you're going to struggle for a while.
Yeah.
And plus, you've got fluid leaking through here, filling this up. It can seep over to the other side
So
too.
you just hurry up paramedics quick.
Yeah, exactly. It's not like, hey, you got shot in that lung, so no big deal. Just it'll heal over because there's going to be fluid. There's going to be bleeding in the lung. They're going to drown in their own lungs.
So, I have a question.
Sure.
Can you go back? Yeah. So we're saying that the pressure doesn't want to like go out like diffusion-wise, but instead it's going to.
What do you mean? If there's a puncture right here, yep, it'll go from here into that. So the 760 will go down into the 756 until this equals 760 also.
Okay, and then can you go back one more?
Yep.
Okay. So that one, we're saying that if it's 756 in that outer one,
Yep, 756.
so something's going to come in.
Yep, this pressure equilibrates with this one, so it's 760 also. All it's showing you is the difference, one coming from the inside of the lung into the pleural cavity, one coming from the outside of the lung into the pleural cavity. It's the same concept either way.
Okay.
So if a bacteria got in here and destroyed this and punctured that wall, it's going to come from the inside of the alveoli and go into the pleural sac. If you get a nail gun out to the outside here, it's going to come from the outside environment into the pleural sac. Either way, it's trying to hit equilibrium with whatever environment it can get access to.
Okay, so it's just always going to try to see it's not.
Yep, it's going to try and hit equilibrium no matter which way. In fact, if a bullet went all the way through, it's going to do the same thing with both sides. It's going to come from both sides and go into that sac.
Okay, so it's not going to do like diffusion or something like that.
It is going from high to low, 760 to 756
Until it reaches.
until it hits equilibrium. And we're 760 to 756 until it hits equilibrium. Right. Okay, did we talk about this one now? Intraalveolar pressure. Oh, here we go. No, these rules, you need to put a star by them, or 10. Yeah. Because these are the rules, I'm going to tell you the details of the rules, but here's the overall picture you want to be looking at. The intraalveolar pressure has to be less than the atmospheric pressure for air to flow where? Think about it. Intraalveolar, inside the lung, is low. Outside is high for air to flow where? Into the lung, right? And then this second one's exactly the opposite. The intraalveolar pressure has to be high compared to the atmospheric for air to flow where? Out. This is the process of breathing. You change the pressure, the intraalveolar pressure. Are you going to change your atmospheric pressure very much? No. For you to make a drastic change like that, you've got to be in some kind of a device that does it for you, or you have to really like take a rocket ship straight up to Colorado where you change the atmospheric pressure really quick. Or space and you open the hatch, right? So anyway, in this situation, it's the intraalveolar pressure you're manipulating. You're changing that pressure. If I want to blow air out, what do I have to do to the pressure in the alveoli? I need to make it very high so that it's over atmospheric pressure, so that the air blasts out into the atmosphere. If I want to bring air in, I have to make the intraalveolar pressure very low so that the air races in from the atmosphere. Right. And then the next one, respiratory muscles that accompany breathing do not act directly on the lungs. What are they acting on? I kind of told you this already. So the thoracic wall is where the skeletal muscle are at, the respiratory muscles. What are they working on? What are they actually pulling? The membrane of what? The pleural sac. What membrane are they pulling on? They're pulling on the parietal, the thoracic wall membrane, right? And as they expand that, what are they expanding? The visceral wall, right? So it's pulling on the parietal wall, pulling all those little water molecules, and they're expanding the visceral wall at the same time. So the respiratory muscles that are allowing you to breathe are not actually pulling on the lung, they're indirectly working on the lung. They're pulling on that parietal wall, which pulls on the water molecules, which pull on the visceral wall, which pull on the alveoli, which increases the size.
Which is like the people holding hands.
Yep, the water molecules are like the people holding hands. Yep.
Does the visceral wall mechanically connect to the lungs? Is it a mechanical connection, or is it just pressure?
It's a connective tissue connection. It's holding on to the alveoli. They're like bound together. They're fused together by connective tissue. So as you pull back and forth.
And that increases pressure?
What increases pressure?
That pulling on the parietal wall, the pull on the water, pulls on the visceral wall, pulls on the alveoli, that increases pressure?
That increases the size of the lungs. Which reduces the pressure. Yep. So if it reduces the pressure inside the lung, what's going to happen to the air? It's going to flow in. If you lower the pressure in the lung, air flows in. Yep. So in that example we were just talking about, by pulling out on the skeletal muscle, pulling it out away from the body, pulling the rib cage out, you're pulling the parietal sac out, you're pulling the water molecules out, you're pulling the visceral sac out, and what are you doing to the size of the alveoli? You're making them bigger, which is going to do what to the pressure in there, which we haven't really talked in detail about, but it decreases the pressure. By decreasing the pressure in the lungs, how is that compared to outside now? It's lower, so where's the air go? Down and into the lungs. What did you just do? You inhaled. You inhaled.
So we reduce the pressure that's in the
So here's another law. You're not going to have to use math. You have to understand how it works. If you increase the volume, like we just said, we just made the size of the alveoli bigger, you have to equally decrease the pressure. This is called inversely proportional, right? If one side increases, the other side has to decrease. So if I double the size of the lung, what did I do to the size of the pressure? I half the size of the pressure. If I compress the lungs to half their size, what did I do to the pressure in there? I just doubled it. And volume is the size, how much space I'm taking up inside the lungs. So if you imagine an alveoli is the size of my hands, you're like, we'll say the size of an apple. If I double the size of the apple, I double the volume of the apple, right? Which would decrease the pressure inside the lungs. Yep. If you increase the volume, increase the size of the lungs, you decrease the pressure. So when you decrease the pressure, what's air want to do? Does it want to race out or race in? It wants to race in. When you drop the pressure, as soon as you drop the pressure below the atmosphere, air naturally wants to go from high to low and wants to race in. and that's Boyle's law. So here's the illustration from the textbook, but here you have a normal chamber. Let's say you're not breathing at all right now. So the volume of your lungs is 1 unit. The pressure is 1 unit. So we'll say volume is 1 liter, pressure is 1 atmosphere, just to make it simple. If I compress the lungs now, I squeeze the lungs to half their size, what did I have to do to the pressure in there? I increased it. All these molecules are in there. They're nice and comfortable, but now I just crowded them. How are you going to feel if I smash the room walls? Let's say I take this room and I cut the size of the room in half. What is your pressure going to feel like? You're going to feel more pressure, right? You're going to feel uncomfortable. You're going to feel crowded. You feel the pressure on you. Are you going to want to stick around in this room? No, you're going to do what? You're going to leave. If I take the lungs and I compress the lungs, I squeeze the alveoli down, and all those air molecules are going, oh my God, it's so crowded in here. There's so much pressure. What are they going to want to do? Leave. What did I just do? I exhaled. Just the opposite. If I have this many air molecules and I take the volume of the room and I expand it way back so that this room is nice and big and comfortable, what do you want to do? Stick around. What do the people outside that are crowded out there want to do? They want to come on in. It's comfortable in here, right? What did I just do? I increased the volume of the lungs. I lowered the pressure, and what happened? I inhaled. I brought air in. All right, so here are the steps of how you use the muscles. You're manipulating skeletal muscle. Are they voluntary or involuntary? They're technically voluntary. Can you hold your breath? Yes, then they're voluntary. Right? So you're going to take these muscles, and you have to remember your anatomy. You have 2 sets of intercostal. What does intercostal mean? Between ribs. It literally means the muscles between the ribs. When you take the intercostals, the external intercostals, and you pull them up and out, it takes your ribs and pulls them up and away from your core, right? What's it doing to the volume of your lungs? Increasing them. What's it doing to the pressure in the lungs? Reducing the pressure. What's it doing to your air now? If you have low pressure in the lungs, high pressure outside, it inhales. It's the external intercostals are responsible for inhalation. What's the other muscle that sits across the bottom of the thoracic cavity? The diaphragm. So the diaphragm normally sits like a rainbow. It's in this arch, right? If I want to increase the volume of the lungs, do I push the diaphragm up or do I pull it down? I pull it down. I pull it down. What's it doing to the length of my lungs? Making them longer, which is doing what to the volume? Making the volume higher. It's like taking a can that's this big and stretching it to this far. I just increased the volume. What happened to the pressure in there? It decreased. What did I just do? Exhale or inhale? I inhale because the high pressure outside now wants to go in. Is it making sense? Okay. I feel like I'm saying the same thing over and over and over again, but I'm hoping that as we take one step further, it keeps bringing you back. So the 2 muscles that are responsible for inspiration, breathing air in, are what? The diaphragm and the external intercostals. They both contract, they both shorten, but they both actually expand the lungs, which does what to the pressure in there? Decreases the pressure. You expand the lungs, you're increasing the volume. You increase the volume, you have to decrease the pressure. It brings air in. This is the trick that gets a lot of people. Guess what muscles you use to relax, breathe out? None. What do? You just turn off the ones you use to breathe in, right? So you breathe in actively, and then when you want to breathe out, you go. You don't force anything out. You just relax those muscles. What is it about the muscles that make them want to snap back to their original position? They're elastic, right? So the elasticity goes, it compresses the lungs. What's it doing to the volume of the lungs? Squeezes them down. It shrinks the volume, so what's it do to the pressure in the lungs? Increases it. Now I have high pressure in my lungs, low pressure comparatively in the atmosphere. What's it do? It goes out. It leaves. So when I contracted the diaphragm, I pulled down, but when I relaxed the diaphragm, what's it do? Its elastic properties go boink and bring it back up into that arch shape. What did it just do to the length of the lungs? Shorten them. What did it do to the volume? It decreased the volume, so what did it do to the pressure in there? Raise the pressure. What's the air do? Pushed out. Before I had these nice round rib cage. Now that I relax those muscles, they go and shrink down. What did it do to the volume? Decrease the volume of the lungs. What did it do to the pressure? Increase the pressure. What's the air going to do? Leave.
I have a question.
Sure.
So when you hold your breath, what's everything doing?
You're freezing everything. When you hold your breath, you're not expanding anything,
So
right?
everything's just sitting there?
So is the pressure changing?
No.
Is the
But
volume
what is it? I
changing?
have no idea.
Is the volume changing?
No.
Nope. So is anything happening? Nothing.
Everything just freezes. in
Freezes.
time, pretty
Yep,
much?
it just freezes. If you take a deep breath and you hold your breath, are you moving your skeletal muscles? Is your rib cage moving? Nope. So are the alveoli moving? No
Blood's
movement.
still flowing.
Blood still flows, but that has nothing to do with the air.
True. Okay. Weird.
Okay, so all those steps I just told you are listed here. So starting one respiratory cycle, imagine. Oh, yeah, go ahead. When you have a collapsed lung, what? They have to puncture, or they have to fill that puncture. So there are a lot of little devices, huh? Every time, exactly, it stays at equilibrium. So every time you inhale, that pleural cavity changes with the atmosphere. So you can never actually pull on the lungs. So what they do, somebody did a presentation on this last semester. They were in the military and they showed the device. They actually showed the device they use. They will put the device into that hole, and it's almost like recorking a wine bottle because it seals that hole, and then they pull. They actually pull the fluid out and they pull the air out. Anybody know what I'm talking about?
Yeah.
Those little devices that.
Last night.
Yeah, it's really cool. And they pull that, vacuum that pressure out so that it actually drops the pressure in that pleural cavity again and allows them to expand it back and forth. Yeah, as long as that hole's still open, you can't create any pressure in there.
So that picture with the equilibrium of the lung pressure inside and outside?
Oh, back at the pneumothorax?
Yeah. I
Okay,
think
yeah.
it's still back from that. That actually makes sense because you don't want it to be equilibrium because then nothing's going in.
You always want the pleural cavity, that pleural fluid, to be what compared to the atmosphere? Always want it to be lower. So when they pull that fluid and they pull that air out to fix a pneumothorax, they're going from 760 at the atmosphere to bring it back down to that 756 so it's lower. You always want it to be lower. Yeah, you always want it to be lower than atmospheric pressure so that when you pull on the atmosphere, it has this negative suction pressure that pulls that wall along with it all the time. If they're at equilibrium, there's no change. Huh? If you, regardless of the atmospheric pressure, yep, that pleural cavity will go to equilibrium with whatever the atmosphere, no matter what level you're at. Okay, so when you look at the respiratory cycle, it's kind of like the cardiac cycle. You want to start at rest. So you're relaxed. So before you actually inspire, you breathe in, everything's relaxed. There's no airflow, right? Your chest isn't moving. There's no air going in and out. Everything's at equilibrium right now. Then what you have to do is you look at the intraalveolar pressure is exactly the same as atmospheric, called equilibrium. What muscles have to contract? The diaphragm and the external intercostals. What are they doing? They're both expanding the lungs. The external intercostals are making the lungs more broad, round. The diaphragm is making it more long. You're increasing the volume dramatically, really quick. What's happening to the pressure? It's decreasing dramatically, really quick. So when you contract these, the diaphragm, external intercostal muscles, and I think you can figure out the nerves that innervate it, but the intercostal nerves, intercostals, and then the phrenic nerve controls the diaphragm. When you stimulate from the medulla oblongata, you send a signal down, and it says, breathe. You start contracting those muscles, breathing in, breathing in, breathing in, and then as soon as you're done at the peak, you're all the way at the peak, the whole time the pressure's been doing what? It's been decreasing, but as soon as you stop at the peak, what happens to the air pressure between the atmosphere and the lungs? It hits equilibrium. Do you hear any movement coming in anymore when you're not expanding your lungs? Nope. So as you're expanding your lungs, the pressure in your lungs goes just below atmosphere the whole time. It's like 759, right? 760 here. So the air's flowing in, trying to catch up, and as soon as you stop, the second that you stop, what happened? Well, at the very peak, you've stopped breathing. You go, equilibrium. As soon as you stop breathing, you're not changing the volume of the lungs, so the pressure's not changing, and it has a chance to hit equilibrium with the atmosphere. So what's the pressure in the lungs when you stop at the peak of inspiration? 760. What's the atmospheric pressure? 760. It's exactly the same. And that's what we have during step 2, is we're changing the size of the lungs. We're dropping the pressure, but when we stop changing the size, what happens to the pressure change? It stops changing too. So it meets that equilibrium. Right? And then number 3, at the end of inspiration, so we're at that peak. Very top. Now you're ready to do what? Relax. You relax. What do those two muscles do? they snap back, right? Their elastic properties bring them back. They're both squeezing on the lungs now. Now that the lungs are moving, the volume is doing what? Decreasing. What's happening to the pressure in there? It's going high, so it goes to 761. As soon as it hits 761, what's the air do? Starts racing out, right? But at the very relaxed point, when I stop breathing again, what does the pressure do? It equilibrates again. So what's happening to air movement? Nothing. Right? So expiration, we already talked about this. When you expire, you just relax the muscles. The pressure in the lungs is slightly higher, pushing the air out until you're completely relaxed again. And then you start the cycle over. What's kind of interesting is this phrenic nerve. Anybody ever had the wind knocked out of them? Did you literally have all of the air pushed out of your lungs? No. What's interesting is that you actually hit the ground, or whatever hit you hard enough, it shocked the phrenic nerve. If you can't fire this nerve, can you fire the muscles going to the diaphragm? No. What's funny is that if you remember it, which I think everybody does, if you've had it happen to you, you never forget it.
Yep.
So when I was a kid, I remember I was playing Tarzan on a willow tree, and all the willow branches snapped. And I remember falling to the ground. All the other kids were looking down at me. You know, it's like one of those photographs that you see all the people standing around the photograph. But they're all looking down at me, and I'm going, I can remember breathing. My lungs were expanding, but was I getting enough air? What muscle wasn't working? The diaphragm. I snapped the phrenic nerve so hard, it shuts off briefly, just like your leg falling asleep. And it's not firing, so you can't fire the diaphragm. So you're going, you're only expanding the external intercostals. None of the diaphragm is firing.
Both nerves are controlled by the medulla.
Both nerves are controlled by the medulla oblongata. Yep. So there's your your actually fact for the day. So when you get the wind knocked out of you, didn't get the wind knocked out, you actually shock the phrenic nerve and it's not firing. That's why if you take martial arts and they tell you if you're about to take a blow to the chest, what do they tell you to do? They tell you exhale, because if you just firm your chest up, that impact might do what? Shock the phrenic nerve, and then what happens? That person just knocked the wind out of you, right? So they tell you exhale as you're taking a punch. I have no idea about martial arts. I've never taken a lesson in my life. I hear things. Okay. Anyway, so those are the muscles being controlled. There's kind of an exception. Forceful breathing or forceful expiration, like forceful expiring out, going forcefully, do you use muscles for that? Yes. If you blow really hard, what muscles do you use? Your abs, right? So you're using your ab muscles. The abs are compressing your abdominal region, so you're squeezing your guts, right? Your guts are squeezing, and they can't just blow out your rear end. They're going to start moving up. What are they doing? They're moving up into your thoracic cage, and what are they doing to your lungs? They're compressing the lungs. They're shrinking the lungs down, making you do what? Raise or lower the volume. You're lowering the volume in the lungs rapidly, which is doing what to the pressure? Increasing the pressure, which is making you do what? Blow the air out quickly. When you're forcefully exhaling, you compress your GI tract, all your GI tract and all of your abdominal organs, and they can't squeeze out your anus, so they squeeze up through your lungs. It's called the Valsalva maneuver, right? So well, let me be specific. The Valsalva maneuver is not blowing out candles. The Valsalva maneuver is when you hear somebody in the stall behind you while you're washing your hands going, they're trying not to let the air out, right? They're holding their breath as much as they can, but they're also squeezing their abdominal muscles. And since it can't compress up, it has to squeeze everything down and out. So there's your second fun actually fact for the day.
Is that why when you have a baby?
And that's exactly when you're having a baby. Exactly. That's the Valsalva maneuver too. They hold their breath and they squeeze, and it's squeezing the baby downwards. And yeah, that's why accidentally some other things happen. And you can use those if you're singing too to help control it. That's why they say use your diaphragm. You can use the diaphragm or the abdominal muscles too. Okay, so that's forceful expiration. Forceful inspiration. So normal breathing uses external intercostals and the diaphragm. But if you want to go, like if somebody's not using the diaphragm, like the kid that gets the wind knocked out of them, what other muscles are they used to try to compensate for the diaphragm not working completely? Look at their neck, right? What's that big massive muscle in the neck? Sternocleidomastoid. It's like bulging out. They're going, they're trying to pull their clavicle up and their first couple ribs up to get that little extra space in the lungs. It's not working so great, and that's why they're struggling, right? And then what do you call those muscles down below the SEM? The scalenes. So those are for what kind of breathing? Forced inspiration. They're trying to expand in. They're expanding everything in their neck and trying to move the top of the ribs. The diaphragm's the powerful air mover, and if you can't get enough movement with the diaphragm, you start depending on all these other muscles. So when you're looking at this, you need to know the 4 different states. Yeah?
So the combination of scaling to the sternocleidomastoid would actually, they increase the volume.
They increase the volume, yeah. Jeff, it's when you think of the lungs, they're biggest at the bottom by the diaphragm, but they're kind of tiny up at the top. And so when you're using those top ones, you're not getting much expansion, but it's a little extra. So exactly, it's better than nothing.
So are they still expanding even in normal inhalation then?
No. No, for normal inhalation, it's your diaphragm and your external
Are you
intercostals.
getting any air into those upper lungs? Are you still getting air into those upper
Oh yeah. Yeah, when you're breathing, your air is distributing evenly across all of your lungs. So when they say that you're a chest breather or a belly breather, what they're just trying to say is how deeply you breathe, not how deep down in the lungs, but how deep your breath is. When you're a chest breather, usually those are tense people, and they take shallow breaths. You don't see their belly move very much, but when you're a belly breather, when your diaphragm compresses, what's your belly going to do? Push out. Yeah, your diaphragm squeezes down and pushes your belly out, so you can actually see it moving down. So when people breathe with their belly, you see that expansion. Yeah. So if you want good air and you're relaxed air, you don't worry about looking whether you have a six-pack abs or a beer gut. You just breathe so that the beer gut is showing. Be proud of it.
But those two muscles increase the volume at the top more than they
Yep,
usually
scaling and SEM increase the volume at the top, and it's for active, like forced inspiration. Forced expiration, you want to use the abdominal muscles. There's actually one other set of muscles that are on the ribs. What are they? The internal. Because the internals are pulling your rib cage down and in really tightly and forcefully. So they're trying to help you squeeze as much as you can out. So when you're coughing, guess what you're using? The internal, internal intercostals are pulling down really quick and forcefully. Your abdominal muscles are pulling in really forcefully, and you're going, That's why if you've been sick for a week and coughing like crazy, when you're over it, how do you feel? You feel like you've been doing ab crunches for the last week, right? So I always tell myself, as soon as I'm over a cold, that's when I'm going to start exercising again, because I already have like 7-day head start. So, get that 2-pack abs. Okay. Right. Beer cut's the other 4 down below. So expiration, remember, expiration's passive. There's no energy required. You just relax the muscles and you breathe out. You breathe in, breathe out. When I was learning Eastern medicine stuff, my shiatsu master he had super strong Asian accent, and it was funny listening to him because it was breathe in and breathe out. Unfortunately, when you would work on someone, he'd tell you to watch their breath because you want them to breathe properly, and it was really uncomfortable because when you were working on a woman, he's like, "Oh, look, she has beautiful breasts." Or if you're feeling her belly, feel the warmth in her belly. Oh, feel the warmth in her belly. Feel the warmth. He was awesome.
Mr. Miyagi.
He was like my Mr. Miyagi, exactly. Yeah, feel the warmth in her belly. So, inspiration. He was an inspiration. Yeah, actually, a lot of the stories that I think about, like the bonsai stuff, he told a story like that every morning before class. It was amazing. So, inspiration, a different kind of inspiration, is when it's active, when you're breathing in. It requires energy. You have to have energy for those muscles to contract. So these are the normal 2 processes. When you're asleep, these 2 are happening constantly back and forth, right? When you wake up, forced expiration, when you want to blow out candles, when you want to cough, that's forced. You use your abdominal muscles and those internal intercostals. When you want to inspire and deep breathe, like if you're going to go underwater, you're going to take a deep, deep breath, you expand everything. You're using your normal inspiration muscles, but you're also firing what 2 groups up here? The scalenes and the SEM, right.
What about when you yawn?
Sure.
Is that forced or is it?
That would, if you're forcing it in forcefully and you're breathing extra air like that, yeah, you're breathing more in, you're using the extra muscles.
So that yawn would be forced then.
Yeah. You can kind of see it, but it's kind of confusing too at the same time because when you're yawning, you're using the muscles in your neck. So, yeah. Yawn, yawn, yawn. Yawn, yawn, yawn. Big ball of yawn. Great. All right. So when you're watching the pictures and how this changes, Here's totally at rest. My atmospheric pressure is what? What's the atmospheric pressure at rest? 760. The intraalveolar at rest is going to be at equilibrium, so it's also 760. Why is this one at 756? Because it stays down below, right? So it stays down lower than atmospheric pressure. It has to. As soon as I start inspiring, what do I do to this parietal wall? I bring it out. What's this visceral wall do as a response? Follows it with it, right? So what happens to the volume of the alveoli? It increases. What's going to happen to the pressure? Decreases. So as soon as it hits 759, all it takes is a little bit lower. Now the air starts racing in. What process are we doing? Inspiration. Yep. And then I'm at the peak. What happens? At the very peak, I stop breathing briefly. Equilibrium again. Whoops. I thought there was another picture. So it's equilibrium. It's going to go back to 760. And then when I start relaxing the muscles, what happens to the volume here? It decreases because the thoracic wall will squeeze down, the water pressure will squeeze down, the visceral wall will squeeze down, decrease my volume, which does what to my pressure? Raises the pressure. What's the air going to do now? It goes from high to low, and it leaves. So that's expiration. So if you watch the pressure inside the pleural cavity, you'll see it actually fluxing always lower than the atmospheric pressure. It always stays lower. So breathing in, breathing out. As you manipulate the atmospheric pressure, that transmural pressure stays consistent with it. This is kind of cool. When we first learned this, we decided to build I don't know, it's way before my time, but scientists decided to build this device that would help people breathe. If they lost control of the nerves going to their lungs or problems with their lungs and they needed help breathing, they would actually put them in this. You know what it is?
A turkey fryer.
It's a turkey fryer, right. It's an iron lung. And when you look at the way this works, it's a long cylinder, an airtight cylinder. They put the person inside the tube like this, and they have basically the structure that goes around their neck, and it holds the air from moving back and forth. It doesn't actually choke them up, their circulation of their brain. And then at the other end, it's like a big syringe. As you pull this out, it's going to pull and do what to the pressure inside the chamber? It's going to decrease the pressure in the chamber. If it decreases the pressure in the chamber, it's going to pull on their skin, which pulls on their muscles, which pulls on the parietal layer of the pleural sac, which pulls on the water, which pulls on the visceral layer of the sac, and does what to the alveoli? Pulls the alveoli out. Their alveoli have access to the atmosphere, so what's it going to do? As you're opening up the alveoli, it decreases the pressure, which makes air do what? Race in. And then when this chamber goes back, it squeezes. It presses down their chest wall, which presses down on the water cavity, which presses down on the alveoli, which squeezes the alveoli, doing what to the pressure? Or I guess what are we doing to the volume? You decrease the volume, which does what to the pressure? Increases it, and it can blow out through their nose. You're breathing for them. Breathe in, breathe out, breathe in, breathe out, back and forth. So yeah, this is back before we actually had smaller ventilation devices. This is old school, yo. All right, so which of the following is a step in the mechanics of breathing? Which of the following is a step in the mechanics of breathing? How about number 1? Air flows into the lung, causing the lungs to expand. No, right? So that's a big no. By the way, that's why you don't hook the air tubes into someone's nose and clip the tube off. Because as you're blowing air in, what's it doing to their lungs? It's like blowing up a balloon at the carnival, right? So it would be expanding it. You just pass high concentration of oxygen into their nostril, and what's it do? The high concentration goes down to the low. Yeah, so it races down faster. So number 1's wrong. Number 2, the thoracic cavity enlarges, causing the alveolar pressure to drop below atmospheric pressure. So thoracic cavity gets larger. Yep, pressure in the alveoli goes down because the volume did what? The volume went up and causes it to drop below atmosphere, which causes what to happen? Inspiration. That looks like a step of inspiration to me. How about number 3? How about the diaphragm pushes up into the thoracic cavity during inspiration? No, if it pushes up, what's it doing to the lungs? Compressing the lungs, smashing the volume, doing what to the pressure? Increasing pressure and blowing air out. So that's definitely wrong. Number 3 is wrong. Number 4, passive expiration requires contraction of the diaphragm. So passive expiration is telling you what's happening with the muscles. Number 1, they're all relaxing. If you contract the diaphragm, by the way, what are you doing? You're bringing it down, increasing the volume of the lungs, which does what? Inspires. Lowers the pressure and inspiration. So number 2 is the right answer. Okay, look at that. Another equation to memorize. Or is it? It's the same one we've seen so many times, right? Just get rid of the word air. It's flow equals pressure divided by resistance. You already know this equation. It's nothing new. Right? And actually, I'm going to skip over these pictures and go straight in. So when we start manipulating the size of the airway, what's the airway we're going to manipulate, by the way? The bronchioles, right? Because the bronchioles are the resistance vessels for air. Actually, let's go back here a second. So let's say this is the bronchiole, and I start compressing it in. What did I do to the radius of the bronchiole? I decrease the radius. What did I do to the resistance? I increase the resistance. What am I doing to flow? I'm decreasing flow. So think about it this way. If that happens, what do I have to do to the pressure to make the flow back to normal? So I increase the resistance. What am I going to have to do to pressure to keep flow consistent? I have to increase it too. So somebody that has constriction of the airway, what do they look like? Relaxed breathing? No, they're going, right? They're forcing inspiration, they're forcing expiration. They're struggling both in and out. Because what are they doing? They're trying to change their what since resistance changed? They're changing the pressure. They're like really dramatically changing the pressure, blowing harder to try and push the air out, and pulling harder to try and bring the air in. So they get the same flow. So watch that pressure and resistance. We'll keep coming back to it again. Next concept, when you look at the airway, okay, this is because of the body needs. Carbon dioxide levels you want to pay attention to. In fact, you want to put a little star by carbon dioxide. The primary determinant of breathing is what? CO2. Most people think it's oxygen, and it's CO2. I think the first day of class I may have actually told you this. When you're blowing up a balloon and you start feeling lightheaded and dizzy, is it because of your oxygen levels? No, you're getting plenty of oxygen. What are you losing? CO2. And what did I tell you to always associate with CO2? Acids. If you're losing lots of CO2, you're losing lots of acids. Why is it you get lightheaded? Because your neurons are now in an environment that's very basic. You lost acids, so now the base is controlling your body. You get weird, tingly, anxious when you get too much base in your brain. What's that state called? Your brain's actually in a state of alkaline. It's very alkaline. Yeah, it's funny. We'll talk about that later with acids and bases too. Your neurons, they get anxious, anxiety-like rapidly fire if they're in an alkaline situation. If they're very acidic, what do they do? Just the opposite. They start shutting down. Diabetic acidosis. Too acidic, what do they start doing? They get really tired. They get sleepy. They look like they're drunk because their neurons are shutting down, just like when you drink too much. Smell like juicy fruit. So you want to watch the carbon dioxide for respiration. It's the primary controller of breathing. All right, so high CO2 dilates the airways. Think about it. If you have too much CO2 in your lungs, what do you want to do to the airway? You want to open it up to do what? Get rid of the CO2. So you can either memorize this or let common sense be your guide. Okay, so high CO2 opens up the airway so you get more air out, more CO2 out. If you have low CO2 in your airways, it actually constricts it down. Your body just assumes that CO2 and O2 work together, right? So if you have low CO2, what do you probably have for oxygen? Probably high oxygen, right? That's what your body assumes. So what's interesting is if somebody's in a very low CO2, or actually we'll say a high CO2 environment, what are they going to start doing? They start breathing heavy. Even if the O2 level is just perfectly normal because it's high CO2, they start breathing heavy, right? If the environment is low in oxygen, but it's low in CO2, what do they start doing? They slow their breathing. Is that a good idea? No, right? So they have slower breathing because they have low CO2. And then they're like, thud. And if I can find it, I'll bring in a picture of a pig in this kind of environment. We can't do these tests on humans, but we can do them on pigs, which is really interesting. And I'll show you what a pig looks like in a high CO2 but low oxygen environment, what it looks like in a low oxygen environment but normal CO2. So carbon dioxide is going to be the primary controller. And what it does to the airways, you have to know. High CO2 dilates to get more CO2 out. Low CO2 constricts to try and keep that CO2 in. All right, number 2, autonomic nervous system. By the way, would this be intrinsic or extrinsic? This is the actual airway controlling the airway. It's intrinsic. Autonomic is telling you automatically it's going to be what? Yep. If it's not the brain, then it's always extrinsic controller. So parasympathetic and sympathetic. Sympathetic is a dilator. It bronchodilates. How could you remember that? Sympathetic, you want to think, run for your life, fight or flight. What should your airway be doing? Opening up to get more air in, right? Parasympathetic, bronchoconstricts, squeezes it down. Right. So when you think of bronchoconstriction, you want to think of things that cause bronchoconstriction. What did we already tell you about CO2? High or low? Low CO2 causes bronchoconstriction, right? What about adrenaline? What would adrenaline do? It's dilator. Yep. So what's the chemical that's associated with the parasympathetic would cause bronchoconstriction? For bronchoconstriction, parasympathetic stimulation, what's the name of the chemical? Acetylcholine, right? ACH. Mustard gas mimics ACH. Cranks up, what's going to do to their GI tract? Turn it up. Diarrhea, vomiting, nausea, upset stomach, etc. Starts making them cry. What's going to do to their airway? Starts constricting it. What's going to do to their ability to breathe? Having difficulty breathing, right? So you want to think of the parasympathetic and acetylcholine cause bronchoconstriction. Bronchodilation, you want to think of what's happening with CO2. So high CO2 makes them want to open up the airway. What about adrenaline? What's it do to the airway? Opens it up. By the way, what's the technical name for adrenaline? Epinephrine, right? If you stab somebody with an EpiPen, what's it do to their airway? Opens it up, right? So they're having this allergic reaction that's constricting their airway. You stab them with an EpiPen, what's it do to the airway? It dilates it. What's epinephrine do to the blood vessels? Constricts, right? What did histamine do to the blood vessels? Opens them up. The blood flows out of the brain to the ground, right? You stab with an EpiPen, it squeezes the blood vessel, forces blood to the brain. The airway and the blood vessels work exactly the opposite in response to epinephrine. It constricts the blood vessels, but it opens the airway, which is good in a fight or flight situation. It's rerouting blood to the important organs, constricting. But it's opening up the airway to get good fresh oxygen in. Right? So what causes the bronchioles to constrict if you're asked a question like this? So bronchoconstriction, what did I tell you want to think about when you see bronchoconstrict? You want to think low carbon dioxide, high acetylcholine, or increased parasympathetic, right?
Yeah.
So which one of these matches that? So if I have an increase in CO2, what's the airway do? Dilates. Ain't. So we cross that one out. How about number 2? Increase in... I already got that one, right? So that one's wrong too. Number 1 and 2 absolutely have to be wrong. So it has to be 3 or 4. So a decrease in carbon dioxide we know, but what about the autonomic nervous system? So a decrease in parasympathetic? What would happen if I decrease the sympathetic?
Oh, you'd increase the parasympathetic usually.
If I decrease the sympathetic, what's it doing to the airway? If I decrease the sympathetic, it's doing what? It's constricting, right? If I decrease the parasympathetic, what's it do? Dilate. Remember last week when I told you think of the accelerator on a car? If you let off the accelerator, your car slows. It doesn't matter if you have a brake or not. You can let off the accelerator and apply the brake, and you get a slower car, right? You always have to look at the sympathetics and parasympathetics and think, do they affect the system? Number 1. What happens if I let off of them, and what happens if I apply them? Okay? So we know, which one did we say it was? Sympathetics. What's causing constriction? So constriction would be an increase in parasympathetics or a decrease in sympathetics. So it's number 3. Yep, decrease in sympathetics. Because if it increases sympathetics, what's it do? It dilates. So decreasing sympathetics would cause constriction. Next one, elastic behavior of the lungs. What's elastic mean? It's not stretchable, it's snap-backable, right? Compliance is the stretchable. Remember, elastic, you can have elastic waistband, but if it's old and worn out, you can still stretch it. It doesn't matter. What's it lose? It's snap-back. So when we talk about elastic recoil, we're talking about the snap-back ability. If you're talking about compliance, you're talking about how stretchable it is. Compliance, I used the example of what last time? I'll give you an example of a balloon. A balloon that's highly compliant, which means it's very stretchable, is one of those big balloons that you go and blow in, like blow in, talk, and blow in, talk, and it just keeps expanding, right? It's extremely stretchable, very compliant. If I say it's not compliant, it was one of those little water ballooning balloons that you try and blow up, but they're not meant for you to blow up, they're meant for water. So you go, it's a solve maneuver, right? And then little tiny expansion. Those are not very compliant. Which ones have better recoil? The little ones or the big ones? The little ones, because as soon as you let off, they go and they blow all the air out fast, right? But the big ones, they go. So a lot of times compliance and recoil don't go perfectly hand in hand. Sometimes they're actually the opposite. When you're young, you have pretty elastic and pretty compliant lungs. But what do you think happens to the elasticity as you age? It decreases. Your lungs become less elastic, which means they don't do what as well? They don't snap back as well. What about the compliance as you age? It actually stays about the same, or sometimes it can actually increase a little bit. You can expand your lungs a little bit more. That's why you see like the old guys with the big barrel chest, right? Their lungs are really compliant. They stretch out, but they don't snap back so well anymore. So they can expand, but the problem is they can't get that air back out. We'll talk about a couple of diseases where we'll talk about these compliance and elasticity too. So compliance, you want to think what? Stretchable. Elastic, you want to think snap-backable. Okay, and then the pulmonary elastic behavior is due to, first, the high elastic connective tissue, that elastin stuff that we talked about before. Very elastic. When you're young and youthful, you got lots of elastic connective tissue. Good snapback. As we age, it's just like your waistband and your underwear. They don't snap back so good. Right, number 2, alveolar surface tension. And that surface tension, remember, it's all, what I want you to think about is things like the fluid inside your lungs. Your lungs have fluid in them. All those water particles that are in your lungs, keeping it nice and moist, they're trying to hold hands, and they're trying to snap together. What are they trying to do to your lungs? They're trying to collapse your lungs. So when you expand them, they're going, no, 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 no. And they're trying to attract magnetically to the other water molecule, and they'll try and do what to your lungs? Pull it back down. It contributes to elasticity. The more wet the inside of your lungs are, the more elastic they become. What was the name of the chemical that I told you reduces surface tension? Surfactant. Surfactant's kind of like this little lipidy molecule that gets in between the water molecules. So if you put a lipid in between two water molecules, what happens to the attraction between those two water molecules? It's reduced. It's like, I thought Bob was over there somewhere, but oh well. Right? It doesn't care so much about the other water molecule. What's it going to let your lungs do? Snap back better or stretch better? Stretch better. So surfactant decreases surface tension, which increases elastic or compliance? Compliance. It increases your compliance. It makes it easier for you to expand. So a baby that's born a little bit prematurely, they can give them artificial surfactant so they can do what with their lungs? They can expand them better. Okay, and then 2 functions. It reduces the elastic recoil so the lungs don't collapse as easy. And this is talking about surfactant. So it reduces elastic recoil, which increases compliance, right? These are both 2 sides of the same coin. Reduces the elasticity, but increases the compliance. So that way you can inhale deeper, better. Here's an example of it. So let's say you have a couple water molecules here. What do these 2 water molecules want to do? They want to hold hands, right? They're attracted towards each other. There's a big pocket of air in here that you don't have in the pleural cavity, so don't get mixed up with the pleural cavity. Pleural cavity is solid water all the way across. They're all holding hands. Here you've got air in the mix. So these 2, water is like a magnet, it has a magnetic attraction. It sees another water molecule, the closer they get, what do they want to do? You want to test this? Go wax your car and then mist across the top of the car. When all those fine water particles start coming close together, what do? They stick. they hit the car and they pull together in this big droplet, and they'll keep pulling together until it's so heavy it rolls off your car. They have this attraction. But if I put a little bit of oil in here, right in here, what happens to the attraction? It reduces it. It's harder to attract, and you have to think three-dimensionally all the way around. So there's actually a water particle floating over here, one over here, one over here. It's kind of like this dome or this ball of water particles. If I put more surfactant in here, it separates those water particles and lets your lungs expand better. All right, so those two forces, these are elastic forces. The next two, you have what are looking at keeping the alveoli open. What allows the alveoli to stay open? The first one is the transmural gradient. Remember, if you pop that transmural gradient, what do the lungs do? They collapse, which is exactly the opposite of keeping them open. So you have that force that's holding the wall in this neutral position, way out here. If you pop the wall, they collapse. Next is pulmonary. Did I hear somebody start saying something? Oh. And then next is pulmonary surfactant, which we talked about 2 slides back. So the more surfactant, it helps the lungs stay open more. And this third one, alveolar interdependence. So that's not independence. What's interdependence mean? Depending on each other, right? So alveolar interdependence is when each of the alveoli hold hands. So if you look at an alveoli here, 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 and here for that bundle, they're all touching each other's walls. If I start pulling this one in, this one tries to collapse, what's it doing to the others? It's trying to stretch them. They don't want that. They want to stay in their own normal shape. So what do? They pull it back, right? So they're pulling back. They're trying to keep their own shape. At the same time, if this one tries to collapse, this one in the middle is going to pull it back open. They depend on each other. They're trying to keep each other open. So when I expand this one, they all expand equally. If I expand this one, they all expand equally. They all work together. Remember what the holes that connect them are called? Pores of cone, right? So they can distribute the air evenly. They all expand evenly. When you pull on one part of this chest wall, it expands the whole chest. Right? And then just the opposite. What are trying to snap the lungs closed? What is trying to collapse the lungs? First is the elasticity. So you have all that elastic tissue around the lung itself trying to collapse it. You know, it's like you go to a buffet, your underpants they want to stay at the regular size, but you just went to the buffet, now they're overstretched, right? They don't want to be there. They're trying to squeeze down. That's why you get that uncomfortable little line on your skin, you know, when you've gained a little weight, because there's that line again, right? So that elastic tissue is trying to collapse your lungs. It's working against all those other 3 factors. And the next one is the alveolar surface tension. That's what particles pulling together. Surface tension is because of what particles? It's not surfactant. That reduces surface tension. Water particles. It's the water particles on the surface of the alveoli pulling together. They're trying to pull. They're trying to collapse your lungs. So the more wet the inside of your lungs are, the more they want to do what? Collapse. So these are the forces that are trying to collapse the lungs. These are the forces that are trying to keep them open. They're always working against each other all the time. So what's a force that's going to keep the alveoli closed? What force wants to keep the alveoli closed? How about number 4, alveolar interdependence? What's it trying to do? They're pulling on each other, trying to do what? Keep it open. How about that pulmonary surfactant stuff? Nope, that one's trying to keep it open too. Remember, babies, you give them a little extra surfactant and it keeps their lungs open. And then, so it's got to be 1 or 2. Surface tension is what trying to pull together? The water particles trying to pull together and collapse the lungs. It's number 2. Okay, and then the law of Laplace. Another French guy. You don't have to memorize this equation. You just have to understand this big principle. He looked at it and said, well, there's a collapsing pressure of the lung, and we take these different factors into account. If we look at this, it says 2 times the surface tension divided by the radius. So if I shrink the radius, what do I do to the collapsing pressure? I increase it. Remember, this is the bottom of the equation. So the smaller the radius, what happens to the lungs? They want to open up well or collapse? The smaller the radius or the smaller the alveoli, the more they want to collapse, right? So if I take this, and here's the rule, of these 2, which one wants to collapse more easily? The small one. The smaller the radius, the more powerful the collapsing. The moral of the story here is that whose lungs are going to be harder to work? An adult lung or a baby lung? A baby lung. Babies spend so much energy trying to breathe. No wonder they sleep so much, right? But anyway, they're constantly trying to keep the alveoli open. As they grow and the alveoli get bigger and bigger, the easier it is to move air back and forth. So the smaller the lungs, the harder it is to move the air because these lungs want to collapse. What can you do to reduce that collapsing tension? Add more surfactant. Yep. So surfactant gets in between and it prevents that collapse. So the whole point of this law of Laplace is that the radius, the smaller the alveoli, the more powerful they want to collapse, the stronger the collapsing pressure. How about the top of that? If I increase the surface tension, what do I do to the collapsing pressure? It's on the top of the equation. What do you know about the top of the equations? Yep, so if I increase the surface tension, I also have to increase the collapsing pressure. So the more water I have in my lungs, what do they want to do? Stay open or collapse? They're more likely to collapse. The wetter the inside of my lungs, the harder it is to open them. They want to collapse. So if I shrink the radius, they want to collapse. If I increase the surface tension, they want to collapse. Okay, what do I give to reduce the surface tension? Surfactant. Surfactant lowers the surface tension, which does what to the collapsing pressure? It lowers the collapsing pressure. It makes them want to open better. Right. So the work of normal breathing requires only about 3% of total energy expenditure. So normal breathing, you spend about 3% of all of your energy breathing normally. That's for quiet, relaxed breathing. There are 4 ways you can increase the work, which makes it harder, which makes you spend more energy breathing. One is when the pulmonary compliance is decreased. What's compliance? Yep. So in other words, when it's less stretchable, you have to put more work into expanding it. One disorder you want to think about is something called pulmonary fibrosis. What's it telling you about the lungs? They're more fibrous. They have more scar tissue around them. Is scar tissue very stretchable? Nope. So it tells you when you have pulmonary fibrosis, what do they have to do to expand their lungs? Put more work into it. They have to put more force into it. The second thing they can do is airway resistance is increased. What disease do you think we're looking at here? Something like asthma or bronchitis. Yep. So with asthma or bronchitis, they both shrink the radius of the bronchioles. What happens to the resistance? The resistance goes up, so what do you have to do to the pressure to get the same flow? You have to put more pressure into it, so they work harder. So an example of this would be something like asthma or bronchitis. The third one, when the elastic recoil is decreased, when the snapback ability is lost, emphysema. In emphysema, they destroy the alveoli. The alveoli connective tissue is just ripped apart because of either atmospheric experience or exposure, like asbestos experience, breathing in toxic chemicals at work, or what do they do to themselves? What do most people with emphysema do to themselves? Smokers. All that smoke decreases the elastic properties of their lungs. So can they get bunches of air into their lungs? Yes, they can. Guess what they can't do? They can't get all the crap out of their lungs, right? So their elastic recoil is decreased. That's why they get how do they describe their chest? Barrel chest. They've got these huge lungs, but the sucky thing is they can't get exchange of oxygen properly. So emphysema is an example here. They can't get this air back out. And the last one, there's a need for more ventilation, such as during exercise. Oops. So as an example, all 3 of these, 1, 2, and 3, for things like pulmonary fibrosis, asthma, emphysema, these people spend about 30% of their normal energy breathing. What was a normal person's breathing, you and me? 3%. Man, so just imagine when you're running on a treadmill really hard, guess how much energy you spend? You bump that 3% all the way up to 5%. Huh? COPD is a combination of bronchitis and emphysema. Yep, real COPD is actually both. They have to have both. Compliance different from what?
Does compliance do anything to air resistance then, or is it just increasing the work of breathing?
Yeah, compliance is just the volume of the lungs. It's how much air is in the actual lungs themselves. Okay, and then in the lab we'll play with spirometry.